Welcome to Podcast UK.
So, you have taken a skin graft, placed it on a wound, and you're hoping that all of the skin graft will survive. This phenomenon, whereby a graft, a devascularized bit of skin, survives by acquiring a blood supply from the wound upon which it is placed, is called in plastic surgery the take. But what things can you do to ensure that all, or at least most, of the graft takes? Hi, I'm Susan McCrossan, a plastic surgery resident in Ireland and the current Plasta president, and on this cappuccino break episode, we shall be discussing how to optimise graft take. So, how can a surgeon optimise graft take? Well, there are patient factors, wound factors, and graft factors that we can manipulate to our advantage. Firstly, the patient should be, as much as possible, well nourished, including minerals and trace elements, and if possible, not be an active smoker. The patient, and this is especially true in our burns patients, should not be in a catabolic phase. Then, we also need a suitable and carefully prepared wound bed. What does this mean exactly? To start with, the wound bed needs to be well vascularized. This is because when grafts are harvested, they, unlike flaps, don't have their own blood supply, and so rely on the wound bed to provide the blood supply. So grafts will not take on an avascular tissue like bare bone, bare cartilage, or bare tendon. By bare, I mean bone, cartilage, or tendon without periosteum, perichondrium, or peritoneum. Periosteum, perichondrium, and peritoneum, which coat bone, cartilage, and tendon respectively, have a healthy network of blood vessels, and thus can support a skin graft. But the surface of bone, cartilage, or tendon without periosteum, perichondrium, or peritoneum are termed bare. Looks stark white, as if it has very few blood vessels, and so cannot support a skin graft. So skin graft on bare bone, cartilage, or tendon will not survive. But of course, there are always exceptions to the rule. The exception to this rule is that grafts can take, to some extent, on a diploic bone of the skull, because the surface of these are reasonably well vascularized, even without the periosteum. For similar reasons of lack of vascularity, grafts also do not take on prosthetic material such as metalwork used in fractures, joint replacements, or mesh material like those used in abdominal perineal reconstruction. Whilst an avascular bed is unacceptable, we also have to ensure that there is no continuing active bleeding or hematoma in the wound bed. Hemostasis of the recipient site must be meticulous, as a hematoma can lift the graft of the bed, stop adherence, and prevent the subsequent stages of skin graft take. Grafts require a clean recipient bed, not contaminated, not dirty, and certainly not infected. Infections with certain microorganisms, specifically Group A beta hemolytic strep, and to a lesser extent Staph aureus, are especially contraindicated, as these bugs secrete proteases, which essentially eat the graft. If you're planning to put your graft in a wound with Group A beta hemolytic strep, I would skip a step and just chuck the graft straight into the bin. Because you're setting yourself and the patient up to fail, because graft take will be poor, if indeed any graft survives. Infection with Staph aureus is also a contraindication, because these bugs love eating graft tissue, although not as completely as its more aggressive cousin, beta hemolytic strep. So, after ensuring an optimal wound bed, we turn our attention to the graft itself. Meticulous surgical technique is imperative. What does this mean exactly? Well, the graft needs to be carefully harvested, handled gently, ensuring that it does not desiccate. Wrapping the graft in a saline silk swab whilst awaiting inset onto the wound bed is recommended. Meshing a split-thickness skin graft is a common practice, and meshing is a technique whereby the skin graft is passed through a machine which creates small, uniformly spaced, full-thickness perforations on the skin. Meshing the graft prevents serous fluid accumulating beneath the graft by allowing the fluid to escape through the holes made in the skin by the mesher. Mesh grafts also facilitate more accurate draping of the graft into the irregular contours of the wound, the nooks and the crannies, so to speak, facilitating optimal contact between the graft and the vascularized recipient bed, thus improving graft take. As an extra advantage, meshing allows split-thickness skin grafts to be expanded so that the graft can be used to cover a larger area. Very useful in larger areas of skin loss, such as in burns cases. where we can mesh the grafts to get different amounts of skin expansion. 1 to 1.5 is standard, but we can also use 1 to 3, 1 to 6, and even 1 to 9. The graft should be laid onto the recipient bed gently, and it is very important to ensure that the shiny side is down onto the recipient bed. This shiny side is the deeper surface of the skin graft, and this needs to be in contact with the wound bed to allow revascularization of the graft. The matte, non-shiny side of the graft is the superficial epidermal layer, and it is important not to mix this up with the shiny side, as the graft would not take if placed upside down onto the superficial epidermal layer. Top tip if you're finding it difficult to identify the shiny side: when the graft has been meshed, the skin edges of the perforations curl down towards the shiny side. Once laid onto the wound bed, the graft often feels stuck down pretty much straight away, as the initial adherence stage of the graft take process happens almost immediately on an optimised bed. Sutures or tissue glue can also be used to secure the graft at the edges. Finally, prevention of shearing forces on the delicate, newly formed blood vessels is important, with both suitable dressings to protect the graft and a well-informed, mindful patient who is also careful with their graft site. Conventional tie-over can be used, especially for smaller grafts. Quilting to inset grafts and reduce shear is also useful. Finally, negative pressure wound therapy has been shown to improve take, as there is ample evidence to show using negative pressure wound therapy decreases seroma, which helps the graft to contour the recipient site, decreases shearing, and also prevents patient tampering to the area. Additionally, immobilizing the limb with a splint, especially over grafts near or over joints, may be necessary and is an important consideration. It's important to note that whilst split thickness skin grafts can be laid on the wound bed with overlap at the perimeter, when insetting a full thickness skin graft, it is imperative to ensure edge-to-edge contact between the graft and wound edges to optimise graft take. So, to summarise, to improve graft take, the key things are a suitably vascular, clean, non-infected recipient site, gentle and meticulous surgical technique, and prevention of shearing forces with appropriate dressings plus or minus immobilization as necessary. For split thickness skin grafts, a mesh or fenestrated graft to prevent hematoma and seroma formation and increases contour contact. For full thickness skin grafts, carefully aligned edge-to-edge contact between graft and wound edges is key. This has been a cappuccino break episode of Podplast UK. Like, share and subscribe, and give us feedback on what you want to hear next.
Podplast UK is a collaboration between UK and Irish plastic surgery trainees and consultants. The content reflects individuals' practice, and opinions may vary. If you have any feedback, do get in touch. We hope that this has been interesting and useful. If it has, remember to follow us for future sessions.